Hello, and welcome to another episode of Cracking Addiction with Philippe and Naren. And in the episode of Cracking Addiction today, we're going to be talking a bit about lifestyle medicine. And we have a special guest with us, Dr. Sam Manger. Dr. Sam Manger is a general practitioner with a focus on lifestyle medicine and mental health. He is the academic lead and senior lecturer of the postgraduate suite of courses, which includes the Master's, Graduate Diploma, Graduate Certificate in Lifestyle Medicine at James Cook University, College of Medicine and Dentistry and GP Training, as well as a Senior Medical Officer in the Mental Health Services with Queensland Health. He is an ambassador for Equally Well Australia and a member of the advisory group of the RACGP's Shaping a Healthy Australia project. Dr. Manger also hosts the GP Show podcast for health professionals and was awarded the RACGP Queensland GP of the Year in 2021. So Sam, thanks for joining us on the program and welcome to Cracking Addiction.
Yeah, thank you for having me.
So I thought I'd start the program off by asking a simple question and a set of definitions. What is lifestyle medicine?
Well, it is what it sounds like. So it's lifestyle as medicine, just as we say exercise as medicine. It's those domains. So using lifestyle assessment and interventions to address the lifestyle and social determinants of health. So the domains are nutrition, obviously, food, movement, sleep, social connection, green scripts or blue scripts like connection with the natural world, social prescribing, and then mind-body aspects like stress management, mindfulness, meditation, and those. And then there's also the drivers of lifestyle medicine. So we talk about health coaching, which is the perfect partner, behavior change methodologies, as well as the way we think about health service delivery and models of care, because these really need to evolve so that we can actually deliver lifestyle assessment and interventions far more efficiently and effectively than we do currently. So it sort of requires a little bit of a reflect there. So essentially, it's kind of like health professionals enacting public health, but at their level, at the individual and the micro levels, whether it's at the clinical level, community level, hospital level, schools, workplaces, and other sort of geographical locations. And it's a huge field because there's subspecialties within it. So there's lifestyle psychiatry, which is plenty of papers on and other sort of fields. And I hope one day to see, lifestyle cardiology and lifestyle endocrinology and other areas, which are, already established in the science, but as a clinical field, it would be nice to see.
Indeed. And you've given a very good description, and it just shows how broad lifestyle medicine is and how many different fields it encompasses. We've got the medical and the allied health aspects of it as well, as you've kind of elucidated there. And I feel lifestyle medicine is getting a bit more attention in the general media as well. But could you explain a bit more about why lifestyle medicine is so relevant as to how we practice medicine, but also how we treat our patients or consumers?
Yeah, I mean, it's a huge thing to say, really. But so obviously, at your point before around allied health, I mean, allied health are experts in their field. Lifestyle medicine doesn't try and be, people who train in lifestyle medicine like myself or teach lifestyle. I'm not trying to make someone to the level of an exercise physiologist or physician because I can't do that. They are absolute experts in their area. But what we're aiming to do is really improve the skills, nonetheless, the knowledge, skills, practice, like I said, the health coaching, behavior change approaches, and then the models of care, the services, so that we can far more effectively do these. Just to sort of clarify that point. The reason it's relevant is, well, first of all, every guideline, Productivity Commission, you look at is recommending, and reports and all this sort of stuff are recommending that we actually address the lifestyle and social determinants of health rather than there's nothing wrong with pharmaceutical and procedural medicine. They're obviously life-saving, life-improving. We've made very impressive gains in that area. But we are absolutely neglecting, and it's sad to say this, but that is what the research says, or largely neglecting addressing those lifestyle and social determinants in a sort of really effective and efficient way. There is a huge burden of chronic disease, which everyone who's a clinician and researcher in health and really probably in society knows. The rates of diabetes type 2, for example, is going up significantly. Obesity, we all know, is going up. We see evidence of atherosclerosis now in 20-year-olds in the heart. We're seeing autoimmune diseases and other neurological diseases related to lifestyle determinants get worse. So these are all the trajectories we're seeing. And then, of course, the costs go up. And it's not just physical health, it's mental health. And there's a lot of evidence demonstrating the relevance of pathophysiology of lifestyle determinants in both physical and mental health. So these trajectories are getting worse. And like I said, the costs on society and individuals is huge. And the costs of treating them with pharmaceutical medicines is huge. We spend about 18% of the health budget on pharmaceutical medicine, only about 6.5% on primary care. So you can see how much we're needing to spend on this major arm of our treatment. So the lifestyle medicine is relevant because we're trying to essentially build the third arm of healthcare in a meaningful way. We know that 90% of cardiac disease can be prevented. We know 80% of diabetes can be prevented, and the list goes on for prevention. But what really excites me is the treatment. I mean, when people realize how powerful lifestyle interventions are in their clinical experience, they do it with patients or they experience it themselves, which is how a lot of doctors come across it, by being unwell themselves and then treating themselves. And you realize how powerful it is. There are some major publications. In the Lancet in 2018-19 published the DIRECT trial, which showed that up to 80% of type 2 diabetes could be put into remission with diet alone. And there are many approaches there, whether it's caloric restriction, fasting, low carb, plant-based, plant-rich, whatever. There are many approaches. You can reverse heart disease. We now know that 40-50% of dementia is related to lifestyle determinants, and that there's more that you can do in that mild cognitive impairment and early dementia than we first thought with lifestyle treatments, which is very exciting. Mental health, I could go on. I give talks for hours about mental health because it's my area of interest. That depression exercise is as effective as psychotherapy and pharmacotherapy in treating depression. And I could go on and on to the various domains about how relevant that is. It's also safe, and also people want it. So it deserves to be recognized as the first line foundational treatment that's essentially non-negotiable, but it needs that, I suppose, that push from a movement sense to make it so.
Absolutely. And from what you're saying, the lifestyle interventions that you've described are both cheap and highly effective, and there's really no downside as opposed to some of the other interventions that we sometimes use in medicine and healthcare. So I guess I'd encourage our listeners and viewers to really consider reviewing lifestyle interventions in the treatments. And there is, as you mentioned, really good and robust evidence for lifestyle interventions. And to try and segue a bit into... Oh, sorry. Go ahead.
I was going to say there's some areas where evidence is very strong. I think mental health, heart disease, metabolic disease, it's pretty strong in heart disease, quite strong in metabolic disease and mental health and a few other disorders. Cognitive health, but some areas that we need more research, and I'm excited about what will come out in that, autoimmune disease, for example. So I think it's a very exciting field to be part of, if I can rally the flag.
Absolutely. And to shift to my area of interest, which is substance use disorders, how relevant, or how is lifestyle medicine relevant in substance use disorders?
Well, I think about this, I sort of break it up into three ways, because the good thing about lifestyle interventions is that they are pan-effective, right? So it's not just like they're just effective for diabetes or for X. They're good for diabetes and for everything else. So it's the same with substance use disorders. People with substance use disorders, as we know, rarely have just a substance abuse disorder. There could be physical health comorbidities, there could be mental health comorbidities, or there could be other sort of unhealthy behaviors that will eventually lead to those sorts of problems. I think about the benefits of lifestyle interventions across three spectrums. One is specific to substance use disorder. One is for the comorbidities, which are obviously depression, anxiety, physical health. And it's important to remember that physical health disorders, or physical illness, and mood disorders are the top two by quite a way risk factors for suicide. So that's very important. And then as behavior, sort of a gateway to more positive and healthful behaviors. So that's another reason that you would want to instigate these lifestyle interventions as a preventative as well as a sort of behavioral, like I said, as a gateway, because generally when people start to experience benefits from these said interventions, whether it's whatever it is, sleep, movement, et cetera, they then generally get a taste of a more positive way of living, and they feel better as a result, and they want more of it. So that's important as a sort of what we call a gateway behavior, the opposite of what you might see with a gateway substance, which sends people in a negative direction potentially. So I think about it across those things. So within those domains, and obviously the problem, it's hard to encapsulate all of this because there's so many domains I'm trying to summarize. So I apologize if I'm talking a bit, but for physical activity, there's some pretty good evidence. There's been some meta-analyses showing, and it's pretty much always moderate to high intensity exercise that is good for most conditions. Just as a side note, light intensity exercise rarely has many benefits, even in heart disease or cognitive function, etc. But that looks like physical activity can increase abstinence rates and ease withdrawal in those with substance use disorders, which is good that it's specific. And also when they did that meta-analysis, they looked across opioids, alcohol, tobacco use disorders, polydrug use, etc. So that's very good. And then probably the next, or one of the other strong sort of domains in lifestyle interventions that is effective is simply social connection, as we would expect. And when you look at the requirement for support and the beneficial aspects of support, so when you look at a lot of the very effective therapeutic plans around here, the peer-led recovery programs, Alcoholics Anonymous or Smart Recovery, which I think is a really excellent service that people should check out, the listeners should check out, because they have online groups, they have, and it's open to all different substances, which is really great. So that's got very good evidence, and often can be more effective than other established treatments here, like CBT. And often people with substance use disorder, when you look at the research, they state that one of those really important factors for maintaining abstinence was that peer support, that social connection element of a supportive relationship. And I think anyone who's gone through, it's all good to talk about. It's all good to talk about the research here, but if we just go back to remember we're humans, and when we relate with other humans, you feel better, right? When you've got someone to share your struggles with and who's also been on a similar path, then it makes things more bearable and improves the resilience of an individual to be able to push through those hard times. And so sometimes we get a little bit lost in, is there a randomized controlled trial for this? Is there a meta? It's like, yeah, okay, but let's just common sense think about this for a second. Of course, a person who's well connected is going to do better, assuming those connections are beneficial, like they would be in a smart recovery program largely. Some of the areas where there's indices of evidence, but not a lot of sort of interventional evidence specific to substance use disorders, are things like sleep interventions and specific stress like relaxation training and even nutritional interventions, medical nutritional therapies and that sort of stuff. But there is still evidence that certainly, obviously, people who suffer from a substance use disorder have very poor sleep, and that worsens outcomes, increases psychiatric condition prevalence and that sort of stuff. So we need to take that very seriously. Stress is obviously very high probability, and concerns around emotional dysregulation in people with substance use disorder. So clearly supporting people with the mental well-being practices, whether it's emotional regulation practices, like simply naming emotions, and there are obviously many types. Relaxation response training, mindfulness. There is some mindfulness we know works very well for anxiety, depression, but there's some evidence says it's not as effective as substance use disorders, and that probably doesn't surprise me a lot. And then nutrition, there's, like I said, not a lot of evidence to say that you can put someone on, say, a Mediterranean diet or a low carb diet or a plant-only diet, and it improves their abstinence rates and reduces their withdrawal symptoms. So we don't have those trials. It would be nice to see them, whether it's true or not. But certainly we know people with substance use disorders frequently suffer from nutritional deficiencies. And we certainly know that, for example, the SMILES trial, and there's been 4 randomized controlled trials now showing that a Mediterranean diet in those with depression improves roughly about a third of people with moderate to severe depression, which is very impressive. And that's across young adolescents, the trials have been done, and adults as well. So clearly providing the brain and the body with the minerals and vitamins and substrates that it needs to operate effectively is good for it, surprisingly. So I think we can deduce that all of these interventions, whether there's a randomized controlled trial or not, should be used. 1, because of common sense, 2, because we understand the mechanisms, and 3, because at least there's some evidence. But of course, more is always needed.
Thanks, Sam. That was a pretty exhaustive list of how relevant lifestyle interventions are in substance use disorder. In fact, I can't imagine why we don't do more of this. But I guess one of the things that I sometimes encounter in my clinical practice is a lot of health practitioners will say, oh, yeah, we know lifestyle interventions are good, but a lot of the people that we deal with in the hospital and outpatient clinics are homeless or quite marginalized. And sometimes it's thought of as lifestyle interventions are something for the middle classes, or it's something to do when someone has got, like, say, some of their baseline needs potentially met. Do you have anything to say with regards to how relevant or how applicable some of these lifestyle interventions can be for that, say, that homeless population or those marginalized groups we sometimes encounter who've got pretty significant substance use disorders?
Okay, well, I'll try and answer that in sort of three frames. One is the sort of broad concept of should we be doing it / do they work or is it relevant? The second is my experience in marginalized groups, and I'll share that. But then and then the third is research. And I can't really speak. I'm not aware of a huge amount of research in specific populations of people who are homeless, for example. So I can't really comment with substance use disorders, and they do lifestyle interventions. That's quite specific research. I can't really comment and say, yes, for sure, we know, and because that's that. But I can certainly say, just from a principle point of view, coming back to my first point, is that absolutely we should be doing it. I mean, we've already highlighted that it can help people and it's safe. And so this is an equity principle to me. Like, if you want to give people the best care, doesn't everyone deserve the best care and medicine they can get? And to me, that includes and must include addressing lifestyle and social determinants. Now, I totally appreciate that these are huge challenges in specific populations, like people with homelessness, and those social determinants like accommodation are really the number one pressing thing that will likely improve their overall standing and situation and prognosis. So fully acknowledge that. But at the same time, it's not that the presence of one need excludes all the presence of others. And so just because people are homeless doesn't mean we don't offer them medication. That would be absurd. So it's the same to me that people say, oh, well, I don't think there's a role for lifestyle. It's like, well, that's absurd, because, and I'll give now an experience for just the population I know quite well because of my experience, as you said, in Queensland Health is with patients with severe mental illness, lots of schizophrenia, bipolar eating disorders, and so severe mental illness. And a lot of these patients are homeless and sort of pending residential care or have come in as being homeless. And so, like, this is a marginalized group. And so, and the evidence here, and this is why Equally Well Australia was set up, because there's been, I can't remember now, but there's been like 40,000 studies or something absurd on the amount of the role of lifestyle interventions sort of across the board. And when they look at that in people with severe mental illness, they see that it's, people with severe mental illness want lifestyle interventions just as much, if not more, actually. They're as effective, meaning that they will quit at the same rates, and they will have a similar response, say, from the nutritional approaches in depression and the other things I said before. So when people say things like that to me, I'm almost cautious of their philosophy that it's almost like a jaded cynicism. So, of course, acknowledging that there are major barriers and there are priorities in their management, aka social work and accommodation. But people say it about people with severe mental illness too. Oh, they're not occupied, they don't care about that, or their weight gain or whatever it is, and or smoking, that's not important. We're just going to treat their mental illness. It's like, oh man, like, give me a break. You treat the whole person. That's what biopsychosocial care is. And one little case study I'll give you, and then that'll be it for my answer. I know they're long answers. Is I had a patient who was in that situation in the ward, admitted, pending some sort of supported care with schizophrenia, and he was sedate all the time. He couldn't work, and they believed he was on very high doses of medication, antipsychotics for his schizophrenia. And it was presumed that was the cause of his sedation. I was running these lifestyle clinics. I did a proper full assessment of his lifestyle determinants. I wondered if it was his sleep, and then there were a few other sort of nuances to this case, obviously, but we ended up running a lifestyle plan, which included a sleep plan, a sleep assessment. He had severe obstructive sleep apnea. He then got on CPAP treatment for that. And then he, just woke up. I couldn't believe it. The next clinic I saw him about a week, he was like a different person. And then he started exercising. He then realized that he didn't really like the feeling of coughing and feeling short of breath. So he quit smoking, and then he became a peer support worker. And that was his path out of desperation and, social despair, because he now had a career, and we could actually build towards that direction. So you don't know where healing and recovery starts. So don't assume that it won't start with some lifestyle determinant.
That's a great answer, and I exhort all our listeners and viewers to try and really use some of these lifestyle interventions. You never know what's going to stick and what's going to be effective for a patient. And as you mentioned, Sam, it is an equity principle. This is stuff that we would offer for all our patients with other conditions. Substance use disorder is no different. I guess something to ask is, how sustainable are these lifestyle interventions? Sometimes people kind of respond well initially, and I guess, do you find that the adherence to some of these lifestyle interventions kind of progresses onwards as the patient's seeing benefits, or do you find that there might be a bit of a drop-off in terms of people adhering to some of these lifestyle interventions in the longer term?
Oh yeah, for sure. That's a problem. It's interesting because it's very interesting when you look at the research here. So certainly in weight loss, that's a real problem, or the inability to maintain weight loss on lifestyle plans. But when weight isn't the goal, and this is important, when weight isn't the goal, but rather targets that are about well-being, like cognitive function, mental health, energy levels, aesthetic things, how you look, or specific measurables like HbA1c and diabetes, or cognitive function, or when there are other metrics, the adherence is a lot higher. And so I think we need to move away. And same, there was actually, I think, was it earlier this year perhaps, or was it 2020? But there was a meta-analysis, and a systematic review done of lifestyle interventions around antenatal period, so to prenatal, before women get pregnant, during pregnancy, and post, showing very consistently how, I think the evidence was that if we did pretty basic lifestyle interventions during antenatal care more effectively, we would save $500 million a year, just because of the less C-sections, the less complications, both to mum and bub, lower NICU admissions, etc. So that was done by Professor Helena T. from Monash. It's an impressive piece of work. And so if we focus on those aspects, that what is relevant to a person, you generally find behavior change, inverted commas, to be far more effective. But having said that, it's not all rosy. It's not panacea. People don't do it sometimes. So that's reality. And that's probably one of the first things I say to clinicians when I'm training them is just remember, we're dealing with humans. We don't do what we're told at the full stop, really. But, we don't do what we're supposed to do. All of us don't. We're all imperfect. So don't expect that from your patients. You've got no idea, you're planting seeds here, and some germinate straight away. People may not be ready to quit smoking, but they may be ready to start walking, or lifting some weights, or, doing whatever, or connecting with an old friend, or going out for a walk in the bush or something. They may be ready to do that, right? So we've got so one, what is success? And two, just accept that everything germinates at different times. And some take years. I've had patients tell me 3 years later, they come back and see me and say, I quit smoking, I did this. I remember you saying that to me. I'm like, oh, yeah, that was a while ago, but yeah, I did. So you got no idea how people take things on. So do it nonetheless. The second thing is, we are not good. And this is, especially what this is potentially controversial to say, but I don't think the healthcare system is very good at supporting health and well-being. I think it's good at reacting to problems. I think it's extremely good at doing that. Trauma, childbirth, safety, infections. We've succeeded enormously in some areas, but what we're not very good at is managing chronic disease yet. And one of the many aspects we need to get much better at is our communication skills and our health coaching skills and our behavior change this understanding of human psychology, the why humans do what they do, and being much better at supporting them in behavior change. So we're not really trained in any of that. I now teach people in it, but that's postgraduate. You don't get taught that in GP training. You get taught a little bit of motivational interviewing in med school if you're at one of those lucky med schools, but there's a way to go. It's a very big field. And then the last thing I'll say to this is that if we're really going to help people be sustainable, then we also need to change the way we deliver healthcare. And I think primary care is kind of archaic, if I was going to be brutally honest. I think we basically hasn't changed in 40 years. In fact, maybe got worse because there's just more disease, more chronic disease, less money relative to the need that we have, more investigations than we've ever had before, more choice of treatments from pharmaceutical than we've ever had before. Things are harder, I'd say. So we haven't evolved with the times. We've got so many impressive ways of doing things now with, push notifications and digital platforms and using the time and waiting rooms and group shared medical approaches and decentralizing healthcare in the sense of workforce, peer support living. I mean, there's so many options for us now to evolve healthcare delivery that will improve, as I just said, with, say, smart recovery and a peer-led recovery. That is more effective than me advising a person to quit a substance use disorder. You know what I mean? So when we realize that actually peer-led is probably more effective than a GP-led, and that's my experience too. When I was working in the hospital and I was running lifestyle clinics, I found consistently that the peer-led lifestyle group that had formed, which was led by a peer support worker, was more effective than the work I was doing. And that's just the reality. So we've got to then think, okay, what do we offer as GPs now? But maybe that's another bigger question. But the point is we need to evolve the way we deliver services.
Absolutely. And I think that's really a clarion call to really think about how we deliver healthcare and the approaches that we use. And we really do need to think about novel techniques and novel methods of delivering healthcare if we're really going to make that meaningful and sustained changes in our patients' lives, which is, I guess, as healthcare practitioners, what we really want. We really want to initiate that change and lead our patients towards good health. And I guess also, this is a bit of a shameless plug to our listeners and viewers, but if you really want to read further into lifestyle interventions in substance use disorders, Sam and I and a few other authors have co-authored a piece in the Australian Journal of General Practice about this very topic that you can access. But I thought, Sam, just to round out this episode of Cracking Addiction, is there anything else that you'd like to tell our listeners and viewers about lifestyle medicine or where they could access more supports? Because I know you're the president of the Australasian Society of Lifestyle Medicine. Is there anything that you would recommend for our listeners and viewers if they've found a bit of an interest in this topic?
Yeah, thanks. I just realized we may not have said that right at the beginning in the bio. But I'm pro bono president, to be very clear. I do it for love, not money. I'm just a volunteer. But thank you. I've spoken enough, but I will just say if people are interested in this area, becoming a member or doing some of the training with the Australian Society of Lifestyle Medicine is wonderful because we've got conferences, we've got fellowship programs, we've got exams, etc., and training packages. But really, it's just, again, about meeting your tribe. You'll just find a lot of other people who just really care about this biopsychosocial way of caring and evolving and the healthcare system, this movement, I suppose. And again, likewise, to address the social determinants of health. I mean, more needs to happen on that front. So if you're liking what you're hearing, then join the crew. It'd be lovely to meet and greet.
Great. Well, thank you very much, Sam, for joining us on this episode of Cracking Addiction, where we've talked about lifestyle interventions and particularly lifestyle interventions in substance use disorder. So to our listeners and viewers, thanks for your attention and bye for now.